Good morning, colleagues, and a very warm welcome to our session. Thank you for registering and joining us, and especially to our online participants, welcome. We can't see you, but we know you can hear us and see us. So the session is on Beyond the FAST Package, moving from research to program implementation and policy, and I'm co-moderating this session with Alison, who is at the back. So you'll hear more from Alison after the break, where she introduces the group work session. Yesterday during the morning session, you heard me briefly talk about the FAST package, which was implemented in both Ghana and Madagascar. And we're basically concerned that most of the time when interventions are put in place, they are done in a scattered manner. For the FAST package, we are interested in putting interventions together and seeing the impact of those interventions. So for the FAST package for genital schistosomiasis, we're interested in diagnosis and treatment, awareness at the community and health facility level, training of medical personnel to recognize and even record information on genital schisto, because we found out in some of our health facilities that the health workers knew next to nothing about it. And then we were linking up with the program also for mass drug administration and community awareness. Following the close of these studies at the end of last year, several questions still remained. We're asking ourselves what FGS-related activities continue to happen in these countries, because we didn't want FGS activities to end after the project. We're asking ourselves, to what extent has FGS been incorporated into curriculum and training in training institutions, both pre-service and in-service training? And then also, how has FGS been integrated into other health and health-related sectors? We had an FGS National Committee that was tasked to ensure that they moved ahead at the end of the project. And then we are asking ourselves, what can we learn from all these experiences to design any kind of research that has the potential for sustainable action in the implementing countries and beyond? So since we completed the FAST package, we've had colleagues from other countries wanting to learn about what we did. And we think that doing this session would expose us to the kind of work we did. So in this session, our colleagues who will be speaking, and I'll be introducing them briefly shortly, will be describing how FGS has been added to the curriculum in various training institutions in the countries, how it has been integrated into other health sectors and routine service delivery, and how countries are being supported in the fight against FGS in their various activities. We hope that we can learn about how countries have moved actions from the research into implementation, look at some operational research priorities that we can garner from this, and then look at the role of national committees in these countries towards program implementation and policy. So for this session, we are going to have presentations from Dr. Joseph Opari, who is the program manager for NTDs in Ghana, and he'll be looking at actions of the FGS national committees following the implementation of the FAST package. We would hear online from Dr. Wisdom Azanu, who is an obstetrician gynecologist. We would hear from Mbola, also online, who is the program manager for Madagascar. Ashley Preston will be talking about sustainable action on FGS in Côte d'Ivoire, and she has her colleague from Côte d'Ivoire here, so they'll be doing this together. And she's a program advisor at Unlimited Health. And then we have, last but not the least, Amadou from WHO. He's the focal person for Schisto, who will be looking at WHO support to address FGS at country level. I'm supposed to show this to all of us to make sure that we remember what is going on. So the meeting is being live streamed. Anything you say will be shown live. So just pay attention to yourself. And the recordings will be made available after the sessions. When we have breaks, the live stream will pause, and the video will come back up for the small group report outs. Breakout sessions don't have interpretation features, so if you speak Spanish or something, you have to find a colleague sitting by you to be able to help. And take a moment to notice the nearest exit. For us, it's behind us, and then we can take it from there. So thank you very much, and I'll pause at this point, and I'll call on Dr. Opare to start it. Thank you. We have post-its by the side, so if you have a question, take note of it, because we'll take the questions at the end, but this is to help you jot down your questions. Thank you. You can stand there and speak directly into the mic, or you can be here, depending on when you want.
Okay, let's join in. Oh, okay. Good morning, ladies and gentlemen. Presentation, please. Maybe this way. You said? Oh, I have it. So good morning once again, ladies and gentlemen. I'm most privileged to present to you the actions of the Female Genital Schistosomiasis National Committee in Ghana following the implementation of the FAST package. And the very first question is, what is the FAST package? We shall get there. So this is the outline of this brief presentation. Ladies and gentlemen, you all know that schistosomiasis is an acute and chronic parasitic disease caused by the black fluke of the genus Schistosoma. It affects so many people in the world, about 1 million, and Ghanaians are also part of that. When we come to Ghana, the Schistosoma haematobium is the most prevalent human schistosome. And you find schistosomiasis in every district in Ghana. The aim of the Ghana Health Service Schistosomiasis program is to eliminate schistosomiasis as a public health problem by the year 2030. So, a couple of years ago, the Neglected Tropical Diseases Program identified the need for Schistosomiasis STH, that is Soil Transmitted Helminths Expert Committee, to guide the program's strategic direction to the control of SCH-STH programming in Ghana. So we collaborated with USAID-funded Act to End Waste program, and we did establish the SCH-STH Expert Committee. That was in February 2021. And soon after that, and I'm privileged to mention over here that the chairperson for the committee is Professor Margaret Japon, the moderator for this section. Right, so at the same time, we came up with the Female Genital Schistosomiasis National Committee, which is a subset of the SCH-STH committee. It was an advisory committee. Initially, we got some little funding from ESPEN, WHO ESPEN, and the membership of this committee comprised of the Public Health Division, where the Neglected Tropical Diseases Program sits. We have the Clinical Care Division of the Ghana Health Service, the Family Health Division, and the Ministry of Health, which is a policy-making body of the Ghana Health Service, and also the Ministry of Education. So, what is the FAST package? That is Female Genital Schistosomiasis Accelerated Scale Together package. And this has a component of diagnosis and treatment, training of medical personnel, awareness, and prevention of new cases of schistosomiasis. And the Female Genital Schistosomiasis National Committee seeks to push this agenda. It's the first package that did introduce this component into the country some few years ago. So this is the composition of the Female Genital Schistosomiasis committee members, and all the other institutions that I mentioned, you find them in here. Okay, so what is the aim of the FGS National Committee? It's very simple. Within the Ghana Health Service, this committee seeks to increase communication and collaboration about female genital schistosomiasis with a longer-term goal of integrating FGS management into existing clinical training and care. So it is a new concept in our system, and this is the committee pushing it through all the faculties in the Ghana Health Service. So we have the program manager, we have the secretariat, and this committee serves as a foundation for future collaboration, integration of other NTD-related activities within the national health system. So, within the first package, right, era, what were you able to achieve? Of course, we did launch the FGS committee a couple of years ago. We had 4 official meetings, held a subcommittee meeting to review committee's program of work, which was very crucial. We did review and adopted the schistosomiasis and female genital schistosomiasis booklet for educators, and this is widely being used in Ghana, and of course, these books were distributed across the country. So we did orientation for district directors of health services group in the eastern region of Ghana, and over here we had about 20 district directors of health services listening to the concept of female genital schistosomiasis. Then we did orientation for regional health directorates on the diagnosis and management of FGS in 4 districts, 4 regions in Ghana. You have the Volta region, Greater Accra, Central and Western regions. And over the 100, thank you, how many minutes? 5 minutes? Oh, good, I'll be fine. Officers were trained. Then as many as 25 district health management teams were trained. And over here, we had nurses, doctors, disease control officers, public health nurses in the diagnosis and management of FGS in Eastern region, Western, Central, Greater Accra, and Volta regions. So, when first package was over, what happened? We continued, somehow, riding on the back of other programs to sustain program meetings. Then we did orient the regional NTD focal persons, deputy directors, public health, pharmacists, SHEP coordinators, that is school health coordinators, and neglected tropical diseases staff members. They were all about 100 on female genital schistosomiasis. And thus we do on a yearly basis anytime we met for national training of trainers. All physician assistants in the Eastern region, 120 of them were oriented. We've started initiating, or we have initiated education on FGS at the OPDs, ANCs, and postnatal clinics in the districts that we have done some training, so that they can start right away at the OPD, do more education on FGS. Community debates in where we have done the training, and also recently there was a call for nationwide FGS prevalence study, and this committee was actively involved in the development of the protocol. Right, so way forward, what are we supposed to do, or what do we plan doing? In the first place, we want to continue the training because we have done only 25 out of 261. So we have a lot of opportunity here to make sure that we get the others trained, and this is where we are soliciting support from potential funders. And also get the FGS committee members actively involved in the execution of the prevalence study, which we got the award. We want to come up with a field guide on the management of FGS and initiate FGS conference in Ghana, where most of you will be called. Right, so these are some of the photos that we got from the field. This one was in Greater Accra region, where we met the officers and trained. This one was in Volta region, the same in Volta region. The director is here. Okay, and you can see myself also hiding somewhere here. Right, this one I was on air on the popular radio station in Ghana, talking about female genital schistosomiasis. Then this one too was in Ouija. It's part of Accra, and you can see, okay, maybe here, you can see Alison was with us, and it was so interesting. Right, we have some challenges, inadequate funding, educational materials, but we have learned that there is a huge gap in knowledge when it comes to female genital schistosomiasis. And we've also learned that if you write on the back of other programs, definitely you should be able to do something on female genital schistosomiasis. We are so privileged to all these organizations, including WHO. Thank you very much.
Thank you very much, Dr. Opari. Okay, thank you very much, Dr. Opari, for that enlightening presentation. I think we'll move straight on to Dr. Azanu. He's online, and we'll listen to his video. Thank you.
I'm Dr. Wisdom Klute Azanu. I'm a consultant obstetrician gynecologist. I'm a urogynecologist as well, and an obstetric fistula surgeon. I'm a senior lecturer at the University of Health and Allied Sciences in Côte, Ghana, where I also double as the head of obstetrics and gynecology department. I was privileged to be one of the participants of the female genital schistosomiasis workshop, that's the FGS FACTS package, where I got to know about female genital schistosomiasis. Awareness about FGS is low, and we have been making efforts to incorporate this into the curriculum of training institutions. I'm here to highlight the individual efforts that people have made at ensuring that our trainees, especially in the health field, are made more aware of female genital schistosomiasis. And so our presentation is on integration of female genital schistosomiasis into the curriculum of health training institutions in Ghana. And I must say that in Ghana, FGS is not yet formally part of the curriculum for health training institutions. However, schistosomiasis, as we all know, is part of most of the curricula, even from the basic school. So at least awareness of schistosomiasis is good, but that of FGS is virtually not mentioned at these levels. This presentation focuses on efforts that we are making to ensure that our training institutions get to know about FGS. A bit of background is that we know that about 56 million women in Sub-Saharan Africa have FGS, and almost 20 million more cases will occur in the next decade unless girls are treated. And that means unless awareness is made and health workers become aware, including the trainees when they graduate, so that on the field they can diagnose and treat, or at least refer to the right places for treatment. Urogenital schisto is endemic throughout Ghana with elevated levels in certain areas, especially the Volta region where the Volta Lake cuts across. A study put it as a prevalence of 10.6% of those diagnosed with schisto, that's the women, have female genital schistosomiasis. This just to give you a picture of the map of Ghana. So the lake, as you can see, is where the endemicity is. You can see the red one showing the high endemic areas, and then the other colors showing the different colors, different codes of endemicity when it comes to female genital schistosomiasis. So virtually all over Ghana, schisto is endemic, and it can be extrapolated to say that female genital schistosomiasis will also be present. The current practice is to mass drug administration among school children and other at-risk groups to ensure that everybody is treated so they don't get schistosomiasis in the first place, and subsequently FGS as a complication amongst the women. It's been found that when it comes to FGS, it's really on the radar of suspicion for health workers. It hardly comes up as a differential diagnosis when patients present with symptoms of FGS. The recommendation has been that medical school, nursing schools, midwifery training institutions, and other healthcare training institutions update their curriculum to include female genital schistosomiasis. This COR is not limited to Ghana alone. There's some CORs from South Africa, Tanzania, and even Nigeria, where it was found that there was poor awareness and knowledge about FGS among female medical and paramedical students, and even among healthcare practitioners. So what effort have we put in at different levels? When it comes to the Ghana College of Physicians and Surgeons, that's the National Postgraduate College of the Doctors in Ghana, as part of one of our annual general meetings, specifically in the year 2022, one of the pre-conference workshops that we had, we tried to add female genital schistosomiasis as a whole topic, where we term recognizing female genital schistosomiasis. I was privileged to have been the presenter of this particular meeting, which was online, a Zoom session, and the audience were mainly obstetrician gynecologists and then residents in training for obstetrics and gynecology. Of course, if this awareness is created, then you can be sure that those in academia, those training the residents, when they get to know this knowledge and awareness about FGS can be transferred and handed down to the trainees, so that by the time you go to the field, you are well equipped to manage, to diagnose, to manage female genital schistosomiasis. Needless to say, majority of those who partook, you could tell that they were not aware of female genital schistosomiasis. I also had the opportunity to organize a CPD event, an online session where the audience was mainly physician assistants, general medical practitioners, midwives, and some nurses. And then this talk was on vaginal discharge. I tried to squeeze in female genital schistosomiasis. And then one could tell that with the questions and the response that came, FGS was new to most of the people. Again, I had an abstract presentation in this year's West Africa College of Surgeons Conference in Lomé in February 2023, where I did some small work on awareness of FGS among training midwives in the Volta region, and I made a presentation of my findings there. In fact, the audience here were obstetrician gynecologists and from generally the West Africa sub-region and other places. And here, a number of people confessed that this was the first time they were hearing of female genital schistosomiasis. Some of them marvel why I did not carry the study amongst the top obstetricians themselves, but went down to the midwifery level. But the reason is that they were now in training and will be living into the various communities. So if their awareness is tested, we give them the requisite knowledge, it will help because they are going down into the various communities where schisto actually exists. So that tells us that it's good to let people know about, our trainees know about female genital schistosomiasis. At the medical school level, my immediate past head of department, who is also involved, in fact, he was one of the facilitators at the workshop, one of the workshops on FGS, is enthused, and then we had meetings in our department, at the Department of Obstetrics and Gynecology in the University of Health and Allied Sciences, UHAS, who everybody in the department as a faculty is aware of female genital schistosomiasis, and we talk about it. We teach our students, the medical students and the physician assistant trainees about FGS. In fact, when you're having tutorials, it's one of the topics we discuss, just to make sure everyone who passes through the medical school is aware of FGS. So should they get to the field, they will be able to deliver. We believe that if this awareness is replicated in other institutions, said that all those in academia get to know about FGS, especially those of us who work in areas, the gynecology departments and units and midwifery aspects, when we get to know about FGS, including the public health workers, this will help in improving awareness, increasing diagnostic abilities, and even treating of FGS. Well, effort is not limited to the medical school and the doctors alone. Again, at the UHAS, the School of Nursing and Midwifery, one of the facilitators who was at the workshop where we had a face-to-face training on FGS happened to be the immediate past dean of the School of Nursing and Midwifery, and she did a great work there. She had a meeting with the faculty in her department, and she actually organized some lectures where faculty and students partook in FGS dissemination awareness forum. And then there's a course, that is gynecology and reproductive tract infections and in the nursing school, which she handled. And in this course, she does her best to talk about female genital schistosomiasis. Interestingly, this course is taken by both the Bachelor of Nursing students and the Bachelor of Midwifery students. So it means that there's a wide coverage of the nursing student community. The advantage is that once again, when they graduate and they move, they can carry this knowledge with them, help with the diagnosis, or at least suspicion of FGS when people from endemic areas come with symptoms and refer to the appropriate quarters for treatment. That's Prof. Donko, and then a team doing their own thing at the School of Nursing and Midwifery in the University of Health and Allied Sciences in Ho, Ghana. At the diploma in nursing and midwifery level, they are also not left out. Again, one of the participants of the FGS Fast Package program was a principal from the Holy Family Nursing and Midwifery Training College in Brekum, Ghana. When she went back, she also organized her staff and then took them through female genital schistosomiasis. That aside, there was a workshop for the students where she presented and taught them about female genital schistosomiasis. With this approach, we believe that if you're able to bring on board all the nursing or tutors of the nursing training colleges, those who deal with the midwifery aspects, to be aware of FGS, we can make our students become more aware about female genital schistosomiasis as they go through the system, eventually graduating and progressing to become the workforce on the field. So that's a picture of Miss Monica Nkrumah and her team. She's nicely delivering a talk about FGS. That's not the end. Again, one of our participants at the FGS Fast Package, who happens to be a District Director of Health Services in the Esio-Jaman district of the Eastern region of Ghana, when they organized their mass drug administration of praziquantel in 2022, usually the attendants or those who participated are taught or told about FGS. Fortunately, there were a group of teachers who partook in this particular one, and she met them and taught them about female genital schistosomiasis. Teaching the teacher about FGS is good because this knowledge is expected to be transferred to the pupils and the students. And they being aware, in fact, when they have the symptoms, they can seek treatment, and of course, treatment is available. This will prevent the complications that come with female genital schistosomiasis when it is not treated. So as I conclude this presentation on the few works that is being done on various aspects to ensure that FGS awareness is created amongst our trainees in the healthcare institutions in Ghana. Officially, there is the push to gradually implement or add female genital schistosomiasis to a curriculum of training institutions, but this one has to be regulated by the regulatory bodies, and this can take some time. So whilst this is officially ongoing, it's good to collaborate with unofficial, with other colleagues, make them aware of female genital schistosomiasis so that we can tell our students about female genital schistosomiasis whilst efforts are being made to formally integrate this into the curriculum. It will not be limited to Ghana alone. We can go to other institutions and neighboring countries as we got to know that the problem of FGS is not limited to Ghana. So I would say that this has been a nice opportunity learning about FGS, and then this effort that is being put in to make sure that students in Ghana, and in fact all over the world, get to know about female genital schistosomiasis. And I want to acknowledge Professor Ernestina Donko, the former Dean of School of Nursing and Midwifery in UHAS, and then Professor Emmanuel Mohed, that's the former head of Obstetrics and Gynecological Department in UHAS. Miss Monica Nkrumah, that's the principal of Holy Family Nursing and Midwifery Training College in Brekum, Ghana. And finally, Miss Rebecca Bante, Director of Health Services, Esio-Jaman District, for their contributions and then for allowing me to make this presentation because of their inputs that they made. Thank you too for your audience. Thank you very much. These are my references.
Thank you, Dr. Azanu. If you can hear us, we appreciate this very much. The NTD roadmap is pushing for country ownership and integration. And I think these are some of the things that are helping to move things forward. All of this was done without funding from anybody. They just piggybacked on existing programs to be able to deliver this. And I think the facilitators were really charged after the training to go forward and do things on their own. So over to all of us in the various countries. Thank you. We'll now move to Ashley for your presentation, the next one. Thank you very much. I hope you are writing your questions down on the post-it so that we can have a session.
That's not my presentation. Keep clicking. Oh, sorry. That's my presentation. Hi, everyone. I'm Ashley Preston from Unlimit Health, and I'm presenting today on the work that's been going on in Côte d'Ivoire on the prevention of FGS. and that's been done in collaboration with the Ministry of Health and particularly the NTD programme. And Dr. Kwame is here today. He's the Schisto focal point from the Ministry of Health. And I'm speaking on his behalf because he's more comfortable speaking in French. But if you do have any questions for him, I'm happy to help try and translate. So just to give a little bit of context on Côte d'Ivoire, the risk of schistosoma haematobium remains high in some locations, as highlighted on the map, the districts labelled in pink. And there was a pilot that was conducted in Subre district on FGS, and highlighted on the map now. And the pilot indicated that there were no routine services available for FGS prevention, including that praziquantel is not routinely available and provided in health centres for FGS. And also that baseline knowledge of FGS amongst health workers is very low. So of those that were trained, at baseline, 37.5% hadn't had heard of FGS. But of those, there was very little understanding of the symptoms or transmission or how it could be prevented. Also from the pilot, it was clear that the baseline knowledge of FGS amongst women aged 15 to 29 years was almost non-existent, and that they indicated that around 52.5% of women could not access praziquantel or felt that they could not on the same day if they considered they had need of it. And based on interviews with women, they indicated that using water sources for daily activities such as farming, as shown in the image on the slide, or other social activities was very common and a culturally acceptable behaviour. So the key focus areas that the Ministry of Health are working towards in their strategy for FGS include, firstly, the prevention of FGS. So that's looking at targeted and regular provision of preventive chemotherapy to women at risk, and also being able to identify those women at risk and really identifying them at the early stages before they progress and develop the morbidity associated with FGS. And the second key aspect is around sustainable integration. So integration with existing sexual and reproductive health services, including both at the health centre level and then also including community outreach. Considering the complete system from community level upwards, so that's also including community health workers, and integration with health information system and also existing reporting and structures and tools. And thinking about improving efficiencies with resources and the targeted use of praziquantel for preventive chemotherapy. Also, two other key aspects of the strategy in Côte d'Ivoire are around training of health workers and the awareness raising amongst women at risk using the validated materials that were developed as part of the pilot study. So the pilot study was conducted as a proof of concept for integration. So prevention services for FGS were integrated into routine HIV/AIDS and sexual reproductive health services, and that was piloted in between November 2020 and April 2021 in 7 health centres in Subre district. And the target population for that was women of 15 to 29 years. The services that they were provided alongside the routine consultation were the provision of preventive chemotherapy with praziquantel, so that's without the use of diagnosis, and also FGS health education. And in total for the pilot, 56 health workers were trained, including doctors, nurses, and midwives, and 30 community health workers who were associated with those health centres and working in the catchment areas. So the results from the pilot were very promising. So through the integration of services, over 8,500 women were reached with preventive chemotherapy and FGS health education. Also, access and awareness was improved from baseline. And health workers had the capacity to provide these prevention services. And also, the learnings that they gained through the training were maintained through the 6 months of implementation. So as you can see in the table, from a survey conducted with patients at baseline 3 months and 6 months, at baseline there were essentially no routine services for FGS, but then at month 3 and at month 6, health workers were discussing FGS health education with women and also offering praziquantel. Through the pilot, there was also a development of a training and learning materials package, and that was developed through a participatory design approach. The package included training materials for health workers and community health workers, and also awareness-raising materials for health workers and community health workers, including a sort of job aid or aid memoir that they could refer to. And then also awareness-raising materials for women at risk, including pictorial guides that community health workers could use to facilitate their explanation of FGS to women in the community, and then information leaflets that the health workers would use to explain to women during the consultation, and then women could take away with them. So all of the materials were reviewed by a sample of health workers and also patients to provide an ongoing improvement process that was iterative throughout the pilot. And throughout the pilot, there were some challenges, and that led to recommendations that the Ministry of Health are working on. So those challenges included health worker workload for the additional services provided. And the recommendations associated with that were to ensure that the health information reporting should be fully integrated with existing systems. Also, that prevention services can be provided to groups of women alongside their routine consultations, and that tasks can be shared between health workers if they're already working in teams. And integration is only appropriate in non-emergency services, so for example, not those services where women are potentially going into labour. And dose polls offer a simple and effective solution compared to weight-based measurements for dose. Also, health centre access was considered a challenge in certain circumstances, so if potentially women would lack transportation, or also if women didn't perceive themselves as having that need to access the services. And recommendations associated with that were that health centre services should be combined with community outreach, and that also the training of community health workers and their involvement is essential. Another challenge was the usability of all prevention messages, particularly if there's not another option for not using those water sources. So that's why it's really important to emphasize preventive chemotherapy alongside other prevention messages. And also the use of the pictorial guide and leaflet really supported that understanding of all of the prevention messages. And then finally, I think this is a common theme among many settings, praziquantel availability. And it's important that mechanisms to ensure that praziquantel is available when these programs move to larger scale. So the plan for the Ministry of Health to scale up these activities is to use a combined health centre and community outreach approach. So at the health centre, they'll improve targeting of the services through the use of the FGS risk assessment questionnaire, and then also have a surveillance system that will help identify women at risk at the health centre, and then use that to target community outreach of preventive chemotherapy and FGS health education. And the idea is to use all of the information gathered to then develop a national strategy. So the goal of that national strategy is to routinely provide these services at scale. And a working group of national experts was formed during the study, including key members from the Ministry of Health NTD programme, HIV, Mother and Child Health, and then also representatives from the National Health Information System and other research institutions. And they were formed to provide that technical and strategic guidance, and will continue to work on developing the national strategy. So I'll stop there, and thanks very much.
Thank you very much, Ashley. It's just amazing to see how far issues of FGS have moved from 2015, when I first heard about it, to today. Several countries are doing a lot of things. Thank you very much for that. So for our final presentation, it's going to be a video from Madagascar.
Hello, everyone. I'm Dr. Mbulati, Vice President of the Culvan Association and coordinator of the Fast Package program in Madagascar. It's a great pleasure for me to give you an overview of the Fast Package program carried out in Madagascar and the impact of the project continues to have. First, I start by telling you about Madagascar and schistosomiasis and FGS here. I'll talk a little about the Fast Package and its main result with spin-off. So for those who don't already know, Madagascar is a big island in the southeast coast of Africa in the Indian Ocean. The population is predominantly young and has a low level of education. Madagascar is considered as a low-income country. Concerning the situation of schistosomiasis, two forms of schistosomiasis, Mansonet and haematobium, are endemic in Madagascar. You can see on the map the schistosomiasis covers almost the entire inland. Schistosomiasis haematobium, the type responsible for genital urinary schistosomiasis, is highly endemic, as seen here in the map. Research from our association and the Bernard Nocht Institute showed in one highly endemic area in the country, the district of Mavoy, that nearly 63% of women enrolled in the study had FGS diagnosed through colposcopy. While we don't know the prevalence of FGS across the country, but we can expect it to be high in some areas. The main national strategy for combating schistosomiasis is the annual mass drug administration of praziquantel targeting school-age children. The MDA in Madagascar is delivered adjacent to schools rather than a school-based distribution. Treatment for schistosomiasis outside of MDA is through the primary health care centers. Now, let me talk a little bit about the FAST package. FGS Accelerated SCAR Together, or FAST package, is an innovation that creates a pathway to scale off proven intervention to address the burden of FGS in girls and women. The FAST package provides a holistic approach to FGS, combining four principal areas of activity. First, ensure community members are aware about FGS and its impact. Secondly, prevent new infections in children and young girls by supporting the annual MDA with praziquantel. Third, train medical personnel to diagnose and treat FGS. And the fourth, provide diagnosis and treatment for FGS. For the FAST package in Madagascar, two districts with high endemicity of haematobium schistosomiasis, Mourdav and Saqqara were chosen in partnership with Madagascar's Ministry of Health. So what are the main results with spin-off of a program? As part of a training of health personnel in the FAST package, we trained 76 providers from across all primary healthcare centers in the 2 districts. In addition, 46 personnel across the country were trained through online training carried out by Bridges to Development and the Geneva Learning Foundation. The enrollment of all individuals into the training was based on personal motivation to learn about FGS and the person's role within the health system. We also trained 22 subject matter experts who could then train others. To ensure the sustainability of FGS training for health workers after the project period, we knew we had to engage Medical Training Institute, and after the project closed last year, 9 institutes continued to include information of FGS for their students. At the 3 largest faculties in Madagascar, FGS is included as part of a training for medical or paramedical students during their placement in obstetrics and gynecology. After project period, WHO Madagascar included FGS in the diagnostic decision tree of major illness in Madagascar. This reinforces health personal training of FGS during their clinical encounters at the primary healthcare level. During project period, we created a monitoring form to record FGS suspected cases for our trained healthcare personnel. During the last phase of the project, healthcare personnel reported diagnosing and treating 57 FGS cases. Since project close, they continue to record with 17 cases recorded. During the FAST package, an education booklet was developed and disseminated to communities and schools in the 2 project districts. To ensure its long-term use and sustainability, we secured from the Ministry of Health and WHO Madagascar the use of a booklet as an official ministerial document for distribution in other districts. It's been less than 1 year since the FAST package project ended. We continue to see the impact of the further implementation of the FAST package as a concept, not a project. So what contributed to sustainability of some of our activities? We identified SMEs as leaders who can implement change in their respective organizations. We had a firm knowledge and understanding the health system in Madagascar so that we could plan the sustainability during the project. We had also high-level support among the Ministry of Health for the concept of FGS integration. However, sustainability has also its challenges. The essablishment of the FGS National Committee in Madagascar was delayed due to bureaucracy and political challenges. Presidentel is not available at primary healthcare centers, so any women with a suspected diagnosis must report to a pharmacy to purchase treatment. We need better engagement of WASH and food security as partners in FGS prevention. And we know that highly endemic areas for haematobium schistosomiasis will likely have high prevalence of FGS, and yet we do not have holistic activities in place in all areas to combat FGS. More work needs to be done. Many thanks for your attention.
Thank you very much, Imbola, for that wonderful presentation. I guess the questions are still coming up. Imbola is not here, but Alison and I are here to hopefully respond. We'll take a short break now. And then when we come back, WHO is going to wrap everything up because we've put him on the spot and says he must tell us what WHO is doing to make sure that these issues move forward. After that, we can have the question and answer session. So thank you. You've all earned your break. Thank you very much for coming. Please come back.
Okay, Dr. Amadou Garba, please go ahead.
Thank you. It's a pleasure, real pleasure for me to be in this symposium and present to you the work WHO is doing with regard to FGS. So I will first maybe recall the global distribution of schistosomiasis, and then I will talk about the work WHO is doing to support FGS work. So schisto is distributed in 78 countries. 50 of them are implementing preventive chemotherapy, meaning mass drug administration with praziquantel. Before, it was 52 countries, but we have removed Indonesia and China, and now the total number of countries is 50. So 264 million people require treatment. And we also got publication and report of transmission of schistosomiasis in Nepal, in Myanmar, and in India. However, this needs to be confirmed. So you can see on this map the global distribution, but haematobium, which is responsible for female genital schistosomiasis, is located in Africa and this part only. So there are reports of haematobium in Myanmar, but this needs to be confirmed. And also haematobium have been also reported in India, and this also needs to be confirmed. So what are the clinical manifestations of schistosomiasis? So we have two forms. We have the genitourinary schistosomiasis, which is due to haematobium, and you have also the intestinal schistosomiasis due to the other species. So the hematuria, blood in urine, is the pathognomonic sign. So you can see here all this. Oh, you can see here. These are urines collected in a school in Niger, and you can see here all these samples, how they look. So children are urinating blood every day, as you can see, and you can imagine the consequence of that. With regard to intestinal schisto, we have haematobium japonicum mekongai. However, the most prevalent actually is S. mansoni. So this can also lead to blood in stools. So what you are seeing here is stool of a preschool-age children in a survey that they conducted some years ago. So they can have blood in stool, diarrhea, anemia, portal hypertension, ascites, and hematemesis. You can see here, this is a picture from Uganda of a young adult vomiting blood in a health facility due to portal hypertension and the dilatation of esophageal varices and rupture, which provide this large hemorrhage and death. So, with regard to female genital schistosomiasis, we have up to 60 million people that are affected, nearly in Africa. And you can see here the clinical signs of this female genital schisto: the vaginal discharge, the itch, the dyspareunia, the contact bleeding during intercourse, the low abdominal pains, the vulvar signs, the irregular period, etc. And people get infected at a very, very early age, as you can see. You see, this is a baby getting in contact with the infected water, and you have the young school, preschool age and school age children also playing in the water and also being infected. And you can see here, this is the place which, where females have mostly in contact, because you have a place for female and a place for men. You can see here, they are washing clothes and they are doing their routine domestic work. So with regard to female genital schistosomiasis, you can have complications such as infertility, fallopian tube obstruction, ectopic pregnancies, hormonal disturbance, etc. And you can see the low birth weight, preterm birth, etc. So what you can see here on this poster done, this is mainly the lower genital tract lesions. You have what people do not see. So FGS is not limited only to this. This is what you can see. But you have what you cannot see, which is also extremely dangerous for the health of women. These are the fallopian tube obstructions, you can see, the ectopic pregnancies, and the bleeding, and the hemorrhage in case of rupture of the fallopian tube, and the death if there is no urgent care provided. And you have also the complication of increasing risk of transmission of HIV to women infected with schistosomiasis. So WHO has provided a tool to help in the diagnosis of schisto. And you all know this booklet, the FGS Atlas, which is available in French and in English. And we are trying to work and complete the Portuguese version. We have also do a lot of advocacy work, because this was not easy at all, even within WHO, to convince our colleagues working on HIV and working on reproductive health, to make them aware of female genital schistosomiasis. And we have been able to do that, and we published together with UNAIDS this advocacy document, the first ever published, advocating for routine clinical care at health facility level to prevent female genital schisto and for treatment, and also for public health interventions to control female genital schisto. The NTD roadmap published 2 years ago also include a lot of priority actions for FGS that are listed here. The improvement of the morbidity management, the integration to the health care system, and also the capacity building for the staff and for people at all levels that are implicated in the control of female genital schistosomiasis. We have been able also to advocate and have objectives related to FGS in the UNAIDS Global Strategy Plan 2021-2026. The new schisto guidelines also that we have published include actions supporting the treatment and prevention of FGS. As you can see, the age group for treatment now have been extended to include adults. all age group from 2 years. It's not only school-age children, because treating adolescent, young girl, and adult women also will reduce the morbidity due to female genital schistosomiasis. In addition, in the same document, the same guidelines also, there is the recommendation 3, which is related to making available praziquantel for the treatment of all people infected by schisto. And with regard to that, I will just add that the former presenters, they talk about the availability of praziquantel. So we have discussed with Merck, and our suggestion is to use the leftover praziquantel tablet in health facility for the routine treatment of women of reproductive age. And this is an important point, provided that the program is going to report on the number of people treated in health facility with this strategy. So you can use the praziquantel, but you have to report yearly saying we have treated this number of adolescents and women of reproductive age with praziquantel. WHO has also published a policy document in collaboration with UNICEF and many other UN organizations to promote the routine treatment of adolescents and women of reproductive age. We are also working on, in WHO to publish a target product profile for female genital schistosomiasis for the diagnostic. So we have a technical advisory group which is working to develop this TPP for the diagnosis of female genital schisto. So in conclusions, preventive chemotherapy with praziquantel is a means to prevent the development of FGS in school-age children. And this is important. In women of reproductive age, the treatment with praziquantel can prevent and reduce the lesions. There are many publications. And it's important to increase the awareness for FGS and a need to integrate FGS treatment in health facility and other delivery platforms. And it's important also to continue assessing the morbidity due to FGS. Thank you.
Thank you very much, Amadou. So now we are moving into question and answer time. Thank you to all of our speakers, and hopefully as you've been hearing the different presentations, I don't know, are you getting some feedback or, yeah? Oh, okay, maybe I just hear it here. Okay, I'll stand over here. As you've heard the different presentations, hopefully you've either noted down some questions or, and so I would invite you to please introduce yourself with your questions. Unfortunately for our live stream audience, there's no way for you to ask any questions, but for anyone in the room, yes, please, to show me. And please introduce yourself just for people in the room.
Thanks, Alison. My name is Teshome Gebre. I'm from the Task Force for Global Health. My question, I think this presentation is very enlightening, all the presentations, and especially, I don't know, it's my first time to note that Ghana has all its districts endemic for schisto. I didn't honestly have this information being in the NTD landscape for several years. Now I have two questions actually in this. The first one is, from all the 3 country presentations, I didn't see a specific prevalence data for FGS. All of them were saying that it's endemic, it's in many places this and that, but they didn't give us any figures. But figures are very important, and at least to start with, for advocacy purpose, for lobbying, and for getting some funding or treatment, medications and so on for the routine health service. I think that's very important. At least in Côte d'Ivoire, I have seen there is there are 2 hyper-endemic districts with red color, and but I don't know still in that one if they had any figure, rough estimation at least. This is one. Number 2 is in the routine health service, when we talk about integration, Amadou has told us a lot about the efforts being made to mainstream it in the existing health system and so on. Those are very important steps, but now my question is, have any of these countries, including Ghana especially, have tried to integrate it with family planning, antenatal care, programs? These are ongoing programs, as far as I know, in most of the health services. So if there has been any effort to really do that, that would be greatly appreciated. Thank you.
So why don't we start with that? I'm going to give Dr. Opare the floor, and I might also ask after he speaks, I don't know if Beth is the right one, or Leslie maybe, to just talk about the upcoming FGS prevalence study that's going to be happening on a global. Maybe Beth can just say a couple words on that. But I'll pass over, sorry, not to put you, I'll give it to Beth, but we'll ask Dr. Opare to comment first.
Thank you very much for the questions. For Ghana, a few years ago we got 10.1% from a small study in the water basin. I think I have it in another presentation this afternoon. But we are fortunate to, I hope Elizabeth is around, we are fortunate to be part of a multi-country study. It was a proposal that Ghana was selected. So very soon there's going to be a big study in Ghana on female genital schistosomiasis, a prevalence study. And Prof. Margaret is part of the leaders, the investigators on that study. So very soon we shall be fine. When we meet like this, maybe next year, we should be able to tell you about the prevalence of schistosomiasis in Ghana. When it comes to integration, from my presentation, I made mention of the committee, the Female Genital Schistosomiasis Committee, and what the aim of the committee. And over there, the composition of the committee members, we have family health in there. You have clinical care. So it's a committee that is made up of various divisions, okay, pulled together to make sure that issues on female genital schistosomiasis are heard in the Ghana Health Service. When it comes to training, the committee is championing that and other things. So family health is included. You have clinical care also in there. NACP, that is National AIDS Control Program, the program manager is part of the committee. So it's a kind of committee made up of the various expertise, okay, from Ghana Health Service to make sure that we move forward issues on female genital schistosomiasis. I don't know whether someone else.
I just want to also add that one of the facilitators, the health workers, she's one of the trainers for cervical cancer screening. So what she's doing with her cohort and the people she trains is for them to be able to detect FGS as part of it. So now she started taking pictures and documenting it on a flip chart when she does the training. So yeah, that's where, and she's also a member of the committee too. Nigeria has some information on the prevalence of it because they had a bigger study that they conducted as part of Countdown. So maybe they can comment on that. The prevalence there is quite high.
Do you want to comment as you're sitting there? Yes, please.
Hi, my name is Omosafia Shinaiki. I'm from Site Service. And so we have been opportune to do a small study in 2 states of Nigeria. And now our study is giving us a prevalence of about 41% from 20 communities in 2 states in Nigeria. So that's quite large.
Are you able to comment, is that through the diagnosis was done through a colposcopy? Okay, okay. Yes, I'll go to Amadou and then to Laura. Sorry. I think your question is
Yeah, I would like just to comment about the prevalence of FGS, because what you're going to report is what you're going to see only in part. Yeah, it will be what you're going to see in the lower genital organs. But you have what is upper that you cannot see. So if you have 41%, in reality it could be 60%. And there is a publication saying that if a woman is infected and you see the schistosomiasis egg, you can assume that this person also has FGS. Because schisto, you have part of the eggs that are released outside, and you have the rest of the eggs which contribute to the morbidity inside the body. It's not, these eggs are not released. They cause the pathology. Thank you.
I'm going to pass to Laura, who had her hand up here. For Nigeria, what was the denominator in your study? In 20 communities. Okay.
Thank you, and thanks for a great session. It's fantastic to see the level of progress and work around FGS, particularly at the global level as well. My question is around the kind of broader social impact of FGS related to stigma and mental well-being, which we know where women have experienced protracted infertility and things can be huge. And I just wondered, in terms of the management strategies that are in place, how much sensitization and awareness has been done around that, and also when we're thinking about prevalence studies, if it's a missed opportunity not to also include associated stigma and mental well-being measurements so that interventions are really, I guess, person-centered.
I'm going to pass to Ashley, if you have any comments on that, and then I think I'll hand over to you just to give a bit of the prevalence study and respond to Laura's questions. Go ahead.
Thanks. Yeah, the the social impact on women is really, really important. And actually, so in Côte d'Ivoire, the health education was a really important aspect of the work in the pilot and ongoing. And what we found is that women, when they heard about because they'd never heard of FGS before, but when they heard about the impact on infertility, that was then a massive motivator for them to participate in the study. And also that's similarly at all levels, really engaged the health workers in how important the work was, and then higher stakeholders as well in their engagement with the expert working group. So it's a really important aspect to take consideration of, and also kind of provide that health education and think about including it in projects.
I'm going to just give the mic to Beth just to tell just briefly about the COR-NTD prevalence study and answer Laura's questions around.
Sure. Yeah, so I think probably a lot of people already know in the room that COR-NTD is getting ready to launch a 6-country, multi-country assessment of prevalence for female genital schistosomiasis. It's been in process for over a year now. In terms of the announcement and the sharing, Pauline Winsey from ESPN shared it out with all of the potential countries who might be interested. We had 15 countries apply for funding, 6 were selected, and all of those were done through a global panel, not at COR-NTD. And then since then, we've been working with clinical case development as well as sampling plans, et cetera. Obviously, there's a lot that's unknown about assessing prevalence of FGS in terms of the relationship to community-level schistosomiasis, the schistosomiasis that's being measured in school-based children, obviously, as that's the main target. But as we know, some locations are moving towards community-wide MDAs as well. So the 6 countries have been selected. They are Tanzania, which is the pilot country, and we just held the first training and kickoff there. Every country will be using the same protocol. And then it's a total of around 10,000 women who are part of the sample size across the 6 countries, which are Tanzania, Nigeria, Ghana. I'll slow it down. Tanzania. See people scribbling. Tanzania, Nigeria, Ghana, as Dr. Opari already mentioned, Senegal, Mali, and Madagascar. So 6 countries that will all be launched within the next 3 to 5 months. So we are hoping and planning that we will have initial data by probably July of next year, sort of our target for some of those. We're waiting on Tanzania data to come back in order to make sure that we have the correct plan. It is a community-based random sampling instead of at a healthcare center, which I think is one of the first, and it's kind of the largest of its size. In terms of the questionnaire specifically and some of the stigma-related questions, we have been working with IHME to include questions that can start developing and targeting the DALIs. We've also been partnering, and we included stigma questions as part of the work. So not just personal stigma, but also community-based stigma. And I think what we found, and probably, and Margaret can speak to this better than anyone, and the others in the room, but it's sometimes hard to tease out the stigma related to FGS as it is to other gynecological and reproductive issues. And so we know that's not going to be a super clean line. We are also asking about care-seeking behavior to try to start targeting where the integration might make the most sense in terms of targeting that if it shows. So we will see. Hold this space, but a lot of information probably next COR-NTD. There'll be, and AS2MH, lots of work.
Thanks, Beth. And I'll go over to Maggie. And just around stigma in the FAST package, we did photo voice, which will be familiar to you in both Ghana and Madagascar, to try and get a sense of what women were experiencing. And the photos, as you might imagine, are always very telling. So, yeah. Thanks for raising that.
Thank you. It's very exciting to be part of this. I'm a newbie to FGS, and it's so heartening to see a new area take off and develop so quickly within the NTD space. I also wanted to thank all the presenters, excellent presentations, and it's really interesting to see the integration, the mainstreaming of FGS in different ways through training, the treatment, and everything else. And I think that can be an example for other NTDs as well of how the mainstreaming can take place. My questions, maybe for the first 2 presenters on the Ghana experience. You both gave really great examples of scaling things up within the health system side of things and the education side of things. It's obviously, you're very knowledgeable in how the system works, and you know which parts of the system to poke in order to get that rapid scale up, so you're not running around the edges madly, but you're able to get that dissemination. My question is related to the link between research and implementation. So what happened before all of that to link research? How did research, or did research play a part in what you did? And what was the link there? And are there still research questions even now that you're scaling up? So thinking back and forth between the research and the implementation space.
I think it's a plug for IR. Yes, I'm going to give this one to Margaret.
Yeah, thank you very much. So the whole FAST package, even though it had the interventions we put in place, had a research component. So we had done a baseline, we had put the interventions in place, and then we did the end line. But I think the one thing that's made a lot of difference in Ghana is the kind of people that came on board. So you had the program manager right from the beginning. I mean, he didn't have a choice, he had to be there. And the National FGS committee, so I happened to chair the Schisto-STH committee, and with the questions about, so should it be the Schisto committee, or should we just have the FGS? I said, look, we want to champion this. Let's have a group, but it can have people from the FGS committee. And what we found out was that the people just got so hooked onto it. I don't know if it's because it's a women's health issue, but people were very passionate about it and just went on and started doing things. So we have a WhatsApp page, and every other week or so, a new person has said, look at what I did in this place. Look at what, and those are some of the stories we compiled. We didn't ask them to do it, you know. Professor Mohe, who unfortunately was unwell, so couldn't be here physically, he says, I've launched the CPD. I said, can I see? Then he shows me the flyer. I had no hand in it. Opari had no. They just went ahead and did it. So it depends on who you bring on board. We had what we call the subject matter expert training. And we didn't leave it to the districts to choose. We felt that we may have just the high-level people come, but we opened it up based on our online training for those who had successfully gone through the entire process. So we had people as young as health information officers who came, and for them, the whole fact that they were sitting at the table with the professors was enough motivation for them, and many of them have just gone ahead and done so many things. They are making presentations here, they are sending you documents to review, and it's like, it just took off. You know, so that's what I was saying, the integration and getting people who are really challenged and who really want to go ahead and do. You don't need to beg them. They are gone, and we need to run after them, and that's what I'm hoping we'll be able to do with FGS and other NTDs. Because as soon as we start saying, wait, we need to do this, then people are just waiting to hear from you. But once we challenge them and they see that it relates to them, they go. That's the experience I've had from the FGS. It has been so fast that sometimes I just can't even keep up with what is happening.
And just one comment to add from Madagascar, with the development of the awareness materials, those were based on research, the baseline findings. And I think the other thing that we did was it took a long time to get official ministerial approval for that document. So it will be used now in the health system, whether or not there's fast package or not. It's now part of it took time. So it was a real, that was a collaboration that we needed to do in order to make sure that information is now there for forever, or as long as they need it. Now, I think you had your hand up first. Yes, Rogers, please.
Yes. Thank you very much. My name is Rogers Nditancho. I'm from Site Service. So great presentation so far. Just some reflection. I think the presentation were very much focused around strengthening the system to detect female FGS. And I was just wondering, because it seems at the moment it's more awareness, and I was wondering whether we can say it's a public health problem. It's a bit of a kind of a stupid question, because we're more strengthening the system. Do we have a public health goal? How do we integrate it into the program activities in terms of indicators around that? And also, is it going to shift the goal pole of elimination as per the WHO criteria? We may not have had a lot of information around that, but it's something maybe we start considering, because if it's not defined, we may eliminate according to WHO and still have very much female genital schistosomiasis still happening, or is it going to run as a program separately? Just some reflection. Thank you very much.
Oh, yeah, okay, do you want to go first, or? Okay, we'll talk about the indicators and then we'll go to Amadou.
Thank you very much. For Ghana, we started, like I said, as far back as 2015 with a countdown. And then one of the things we found out was that even though they are reporting other NTDs in the health system, the routine health system, the DHIS2, there was nothing on FGS or even genital schisto. So we sat on the necks of the program people and said, you must put an indicator there, because anything that gets reported gets counted. And once the health workers are challenged to report it, they have to give an account of it. So it took quite a bit of time. But then now, if you go into DIMS, you have the indicators. Now, the challenge we have is they are reporting things, but we haven't gone to verify what it is they are reporting, which is something on our agenda that we want to do. As part of some of this work we are doing, to be able to say, okay, this is what you reported. We need detailed information about these people to be able to do a follow-up, because before you look at the data, nothing was being reported. But now, a few things are being reported. I guess it's coming from all the sensitization, but we need to do the follow-up to see what exactly they reported as genital schisto.
Yeah, I would like to thank the person who asked the question because normally I should talk about it because actually WHO is working on indicators for health facility, and FGS is among the indicators to be collected. So we know that it's not going to be easy and it's not going to start now, but we want to be sure that it is among the indicators for the health facility data to be collected, and also for the health information system. So we are going to publish that very soon, and the people will see all the indicators that WHO recommend to collect at health facility base. But FGS is part of it.
So I think we've got time. I saw 2 hands up, and then I think we'll need to go to a break. So I think you had your hand up, and then in the back, and then hold on. Yeah, thank you.
Hello, my name is Vetu Fiawokome from Ghana, and with this research center in Cameroon, Center for Research in Filariasis and Other Tropical Diseases. So this question is to Ghana. So it's good to be able to integrate the FGS into the training institutions, the nurses, the doctors. This, I understand, is to enhance case detection. Yeah, so before the WHO person talked about how to get the praziquantel, what was the strategy? Because the praziquantel is predominantly for the school children. So when you detect the cases, what was the strategy to treat these cases that you would identify if the intervention is well-rooted and it's being picked up in the facilities?
Anytime we had mass drug administration, after the exercise, all the open bottles, we keep them, of praziquantel, we keep them at the health facility level. The unopened ones, we sent them to the regional medical stores for the next exercise. So this is what we do. It's not new. This is what we do. Yeah. Well, I can't talk to that, but it depends on, we treat on case basis, like test and treat. So we keep them at the health facilities. So if you come to the health facility, maybe with blood in urine or whatever, experiencing this kind of symptoms, the doctors diagnose you. We go to the lab. If it's found out that we are positive for an ova of the schistosome, we are given a praziquantel. But most times it's not enough. That one I do agree with you. Yeah, exactly. Yeah, but yeah, exactly. Okay, 2 minutes. Okay, so now we're also appealing to the local manufacturers. We've been in discussion with NS Chemist. NS Chemist is a popular pharmaceutical company in Ghana. Recently, they even donated some praziquantel, and other medication which we give to other places. And we also have some partners coming on board. Good Neighbors also has donated some praziquantel, right? So locally, we are kind of telling people, soliciting for additional praziquantel to supplement whatever we get from Merck. Yeah, and now that, it's also becoming popular that we keep whatever is left at the facility level. That's also okay. Formerly, we were not that sure, but we had that information. That was what we were doing. But now it has been officialized. So we are going to keep on doing that. Thank
you. We've got 1 minute left, so as I walk through, I'm going to say thank you for that question because it's really important. As we raise awareness about FGS, we need to be able to have treatment for them. Very briefly, please, sorry.
So my question may be specifically to Professor Japon. Two-pronged question. I'm just asking, do you think, or where do you think we dropped the ball till FGS became such a problem? Is there any learning that we can learn, we can take from this for other diseases we may be looking at in future? And also, I know that obviously, as we've started looking at prevalence and all that, we would definitely get to elimination goals and all that. Looking at all the other NTDs we've been working on, are there lessons from them that we can take, infuse in tackling FGS, so that we don't go at the end of the day and begin to come back and remaneuver our ways around some indicators?
I'll give you time to reflect. You want me to walk slowly?
I don't know, but you know, in 2005, I was asked to do a review of gender and tropical diseases for TDR. And as part of that, of course, schisto was part of it. And I did write in that document the consequences of schisto, and FGS was one of them. But I just did it as an assignment and handed it over to WHO and forgot about it. I talked about 2015 when I was invited to a workshop in South Africa. And at that time, colleagues from the Netherlands and Germany were doing parasitological studies on FGS. But when I was told to make a presentation on putting FGS on the maternal health agenda, I told Russ from Liverpool School that I don't know what it is. He says, just go talk about it. So I had to go and read about it. And I used lymphatic filariasis and the advocacy approach we used as an example, all right? But then when I was preparing for that talk, then I found that WHO document and realized I had cited FGS as a consequence of schisto. And from then on, with the team in Countdown, they said the first approach was to document it in a non-traditional journal. So we used open democracy, where literally journalists and everybody reads, and that's where our first publication went. So it just came up, but I think that it's moving this fast, like I said earlier, because it's a maternal health issue. And there has been the link with HIV. So the HIV program has taken it up, and there's a joint document, and it's just going just like that. I mean, between 2015 and today, the number of papers, the number of research work that have gone on in FGS is just overwhelming. Is it that maternal and child health issues get quickly taken up and moved on? We are talking about the last tag, NTD tag, we're talking about integration. Does it have to be called an NTD before it works? Or should it fit in maternal health so that NTD can work with maternal health? At the end of the day, it's a human being who belongs to a community who is suffering a condition that needs help. She doesn't care whether it sits in maternal health or it sits in NTD. We have done the fragmentation and say it's an NTD or it is here. The woman wants help. Whatever way we can give her the help, she doesn't care. So we need to put in the effort to see that we are dealing with a human being who may have schisto, who may have LF, who may have trachoma, who may have everything, and she just wants to be well. So it is up to us to look at this in a more holistic way, and I keep talking about it. What lessons do we learn from other NTDs? Advocacy, engaging stakeholders properly and listening to the voices of people in the community, rather than we deciding that we know the answers to everything. Listen to what is going on there in the community, and I cannot overemphasize qualitative research, stakeholder engagement, implementation research, working with the programs to understand what their issues are. Of course, we need to understand the clinical, we need to understand the pathological, but we need to work together to make sure that we can deal with this in a holistic way. Sorry, when I talk FGS, I get very passionate.
Thanks, Margaret. Thanks for all your questions, everyone. That's fantastic. We're going to move into smaller groups and get some. One of the goals of these sessions is to create some operational research priorities for COR and for the community. And so we've got 3 questions on the wall. The first one will be chaired, the discussion will be moderated by Dr. Opare, and it's around the balance between the value of in-service versus curriculum change for FGS. So we know that we need to improve training. So what's the balance here? The if and when training should be integrated into the system. So that'll be one group. The second group is with Laura's here. Sorry, you're in the wrong spots. Are you? The second group here will be with Laura Dean from the Liverpool School. How can FGS operational and implementation research contribute to health system strengthening? And considering those health system building blocks. So we've talked a lot about the health service delivery and health personnel and community, but there are also other elements. Praziquantal obviously falls into procurement and medicine, so important to think about that. And then the third question, which Ashley will take, will be moderating. What are the operational and implementation research questions needed to support the integration of FGS into the health system? So bearing in mind that we need to address FGS in an integrated manner and in a holistic manner, as Margaret has highlighted just now. And so keeping that in the back of your mind as we consider these questions. So what I'd ask you to do is just sort of self-identify into one of these groups to begin. And then at the 15-minute mark, we'll shift. And the moderators will stay put, and you guys shift, and you'll get to all three questions. So please. What we're going to do is ask each of the moderators to report back on your discussion. Take a just high level. We've got about 15, 20 minutes left in the session, so we want to end on time. So we'll hand over to the moderators just to give us a summary of the high points from your discussions. So as you're number one, are you comfortable going first? All right. You know we ran out of time. So you just got to do 2 out of 3 questions. But there's no reason why you can't provide input if you'd like. So we'll go to Dr. Opara here, who is going to give us a high-level 30,000-foot view of your discussion. All right, go for it.
Okay, thank you so very much. Our section was quite interesting, right? And this is the point. We want to integrate FGS into the health delivery system. Where should we start from? What should be considered? Pre-service, in-service. What are the key issues we need to consider? We all agreed that training should be very well done. Training in all areas. We need some training at the pre-service level. We need training also at the in-service level. But in the training, we must bring in more practical sections at the pre-service and the in-service. And we have to look at the curriculum. We have to make sure that we bring the main ingredients when it comes to management of FGS into the curriculum. Good. We also said that as we train, we need to monitor, supervise whatever has been taught in school, either in school or at the in-service level. So periodically, there should be monitoring of and supervision of the health workers as to whether they are doing exactly what they were taught at school or during the in-service training. Then there should be, in the training, we have to look at diagnosis of FGS. At the pre-service level, we have to do much on that, and also at the in-service level, there should be a lot of work. Then we need the people. We have to generate the interest of the trainees when it comes to on FGS, okay, because you could be trained somewhere, but when you come out, if the interest is not there, you may not pursue that. So we need a human resource interested in FGS at the school level and also during the in-service training section. So these are the few issues that we came up with. We still have more ideas, but for the sake of time, we shall leave it here. Thank you very much.
Thank you very much, Dr. Opare. And okay, any other points that anyone wants to raise from that group? Otherwise, I'll go to number 2. I think you summarized well. Yes, ma'am.
Just listening to the group, I think one important thing they talked about was the cycle of curriculum revision. Because if you do this and you don't target when the revision is happening, then you are going to miss out on whatever is happening here.
And I think it's also a point, there are different groups that are working on this in different countries, as we've heard today. And so there is some efforts to try and coordinate some of that work so that there would be a basis for providing for countries an initial curriculum that can be built upon or tailored for that country. So thank you, Dr. Opari, and members of Group 1. Now we'll come to you, Dr. Dean.
Thank you. So we were Group 2, and we were thinking around health systems building blocks and different questions. So I will try and summarize linked to building blocks, but forgive me if I create my own. In terms of the supply chain and data management, we had quite an interesting discussion. Definitely a need for more research on availability and supply of praziquantel, thinking about medicine expiration and how it's stored and transported. And then I think we also had quite an interesting discussion around the real need or not for ongoing prevalence surveys, how accurate they will be with constant cycles of reinfection, and actually perhaps a larger portion of effort needs to be on strengthening systems to deliver a service. Then we talked in terms of health financing around really needing to understand how much it costs to provide FGS integrated services at all levels. So also thinking about communicating at the community level, services being free potentially. Also thinking about how FGS maybe needs to be added into health insurance schemes, not just treatment, but perhaps screening tests. We talked a little bit about the need at the governance level around intersectoral collaboration with WASH and the education sector, and then also thinking about what we could learn around how advocacy has been done in collaboration with other kind of sectors of the ministry for other NTDs as well. We've then focused a lot on service delivery across different kind of domains of service delivery. Some suggestions around kind of and what has been useful in other NTDs in terms of skin camps. Maybe there could be FGS camps where women could have education around FGS and all be treated with praziquantel on kind of a mass treatment level. Talked a lot about how trust is enhanced when women are accessing services and getting services to cure their problems, and what that means in terms of continuous and improved health seeking, and who should be part of those health seeking journeys, maybe different health providers in communities as well as community health workers. Talked about the need for social science, participatory approaches, citizen science approaches. We also talked about a need for maybe more acceptability studies on symptomatic-based treatment with praziquantel, when we know praziquantel has a lot of kind of social issues around taking it or not taking it. And then some studies around praziquantel itself and what's the impact of praziquantel treatment on infertility. And I think that's it. Sorry, that was a bit rambly.
No, it was great. Thank you very much. It's a good agenda that's been laid out. So thank you very much to everyone who participated.
Thanks. So we were working on the third question around what are the operational and implementation research questions needed to support the integration of FGS into the health system. So excuse me if I jump around a bit with all the notes. But the sort of thinking around understanding the context, there are a few questions around that. So thinking around an analysis of the gaps in the health system, thinking about those building blocks as well that were already mentioned, and thinking about assessing the available integration points. So considering as well, what are those health services that are available that can be effective integration points? Another aspect of the context was understanding already what is the health-seeking behaviour, thinking about also the role of sort of traditional or community level health entry points like community health workers or traditional healers, and then also understanding how women interact and have their concepts of those traditional healers, but also their understanding of fertility and their baseline knowledge of FGS. There were also more around sort of understanding the best entry points in the health system from the target population perspective, thinking about how they, what points they access it. And then from the level of the health workers, and also thinking about what levels of the health system need to be involved, for example, when considering treatment pathways or referral pathways, and potentially not just narrowing down to the sort of health centre pathway, but also thinking about other programs that could be involved. What are the opportunities with, for example, schisto control? Also understanding around gender and how that can impact access and other barriers and facilitators that other studies have already found. And of course, that's going to be very context specific. And then there was a good discussion around what resources are required to support integration. And that covered quite a lot. So that could be cost and having a cost analysis, also around equipment and resources like praziquantel. Also the impact on the health system. So thinking around the capacity, what training is required, how that can be integrated into the curriculum. And then also understanding around indicators, what are the requirements for those, and then how can they actually be effectively used for programmatic decision making. And then thinking about as well how to, what are the services that we're actually trying to implement. Are they, for example, diagnosis and treatment purely? Are they also including prevention? And then what are the gaps in understanding of those services? So a really good point raised was around what are the effective ways to diagnose and how could we train on that? Well, I think that was everything.
Great. It sounds like there was very good conversations in each of them. I just caught the side end of some of them. So thank you very much to our moderators who stepped in today and helped bring us through the conversation. So just in closing, we've got a couple minutes left, so I'll just say a couple of things and then pass over to Margaret for any final remarks. But I think that we've achieved what we set out to do today, which is to try and identify some operational research perspectives and also to understand what are the implications for integration in the health service. And I think we've seen with FGS, we can't do it as a standalone. It's got to be integrated. There are good entry points within the health system, but integration takes time. It's not something we do overnight. It's a different kind of research that needs to be done in order to understand the bottlenecks and how do we achieve those solutions, different kinds of partnerships. And so I think we've hinted at some of these today in the conversations moving forward. The availability of praziquantel is the big elephant in the room in terms of we raise awareness, we train clinicians and health workforce to identify, but ethically we need to make sure women have access and that they aren't having to go to the pharmacy and spend a lot of money for it privately. So I think this remains an important question, and I think WHO has given us some direction moving forward in terms of utilization of the donated treatments. However, I think it's still a question that is important for sustainability of our programs moving forward. The one thing that occurs to me, my background is largely in LF. In LF, we have a very strong preventive chemotherapy plus morbidity management. And I think FGS is new, but it's really not. It's the morbidity management side of schisto elimination. And so I think, by thinking through how we're going to implement change within the health system, effectively we're helping to make that morbidity management part of the system moving forward, which is something in the LF community. Often you get to the end of preventive chemotherapy and then you're scrambling to make sure your morbidity management systems are in place. And I feel like here there's an opportunity to make sure that morbidity management is in place as elimination is moving forward. So I really see it in that, in framing it that way in my mind. thank you for bringing up stigma and the importance of understanding the impact on women and girls at the end of the day. They are the ones who we need to remember in the work that we're doing, and so appreciate that that was raised as well today. So thank you from my perspective, and I'll give the last words to Margaret. So thank you to our speakers, and pass over to Margaret for any final comments. Oh. Yes. Yes, okay, go for it.
I'm not sure if I've heard the issue of perhaps recruiting only women health workers, especially at the community level, to identify the cases, because this is very personal and women might be shy to really speak. And I don't know if this has come up in any of the groups, but I think this is a very critical one. Thank you.
Yeah, I think it's probably one that could sit in either one of these, and certainly our FAST research showed that women more likely to talk about their health-seeking behavior with other women enumerators. Yeah, so thank you for raising that. Yeah, okay, over to you.
So thank you, Alison. I think she's raised all the issues, but I just want to add that this is just the beginning of many more discussions that we can have together as a team. We have your contacts, I think, and email, because we have a list of all those who signed up here. We'll make sure that we keep in touch, so that if somebody's doing something somewhere, we can learn from each other, and then we can look at how we can collaborate on further work that needs to be done on FGS. Thank you very much for helping us get this session going, and have a wonderful lunch.